Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another lecture. Today we are going to study about the retinal tears and holes. So retinal tears and holes are basically these breaks that develop within the retina because of various reasons. So either it could be the traction of the separating vitreous on the retina that can lead to retinal breaks, or it could be because of degeneration and thinning out of the retina that can lead to formation of holes, or it could be some trauma, for example blunt trauma, that can lead to development of multiple retinal breaks. Okay, now over here let us understand this. In the first picture, as you can see, this is actually a hole, and this hole has basically developed because of the eventual thinning or the degeneration of the retina. Over here there is no role of the posterior vitreous detachment, whereas in the second picture you can see that in some areas of the retina usually we will have dense vitreous adhesion to the retina, like in the areas of lattice, nail tract degeneration, other degenerations, and also at the vitreous base. So when the vitreous starts separating from the retina and when it reaches these locations of dense vitreous adhesion, the vitreous is also going to pull a part of the retina along with it, leading to formation of these breaks in the retina or the retinal tears. Okay, so vitreoretinal traction is another cause of development of retinal breaks. Similarly, trauma is another cause of development of retinal breaks. In the first picture, you can see that this area basically is an unsupported zone and also has a thinner sclera. Also, the vitreous base is very firmly attached to the retina is very firmly attached to the vitreous base, right? So now, whenever there is a blunt trauma, what happens is that the force of the trauma is going to lead to compression of the eyeball, and there will be expansion at the level of the equator. Now, because of that compressive force, because of that equatorial expansion of the eyeball, there can be various tears that can develop at the level of the equator and also anterior to the equator. And the most common tear that we see developing post-trauma is the dialysis of the retina. Okay, so we'll talk about that in detail. Now, the thing is, why are we talking about these retinal breaks? What is its significance? Now, we know that sitting in front of the retina is your vitreous is situated in the vitreous cavity, right? Now, if there are some breaks that develop within the retina, these breaks may allow the liquid from the liquefied vitreous in the vitreous cavity to enter the potential space which is present between the neurosensory retina and the retinal pigment epithelium, and as fluid passes through these breaks into that potential space, it causes separation or lifting up of the neurosensory retina from the retinal pigment epithelium, leading to what is known as a retinal detachment. And now here, because the retinal detachment is occurring because of the retinal breaks, this is known as a rhegmatogenous retinal detachment. So I hope that is clear. Okay, now the question is, how do you basically identify these breaks? These breaks are usually located in the peripheral area, right? So a 360 degrees fundus examination using an indirect ophthalmoscopy is really important, and special attention should be given to the use of scleral depression or indentation. Okay, so when you do scleral depression or indentation, you will be actually able to see far off in the periphery as well. And often you should know that these breaks are not so isolated. Many a times you will find multiple retinal breaks present at the same time, and therefore the examiner must thoroughly examine 360 degrees of the fundus in order to locate all the breaks. Okay, and whenever multiple breaks are present, they are usually present within 90 degrees of one another. So what I mean to say is that if you find a break like this in this area, there are 75% chances that you will find another break 90 degrees apart from this, or within the 90 degrees of this original break. So you might find a break here, you might find a break over here, right? So therefore thorough retinal examination is very, very important. Now let us see what are the types of retinal breaks that we are going to discuss in this video. We'll talk about the atrophic retinal holes, operculated retinal holes, horseshoe shaped tears, also known as the flap tears, giant retinal tears, and giant retinal dialysis. Okay, now let us begin first with the atrophic retinal holes. Now, these are actually the most commonly found holes or retinal breaks during the routine examination of the peripheral retina. You can see one which is present over here in this picture. Right? Now, as the name suggests, an atrophic retinal hole is actually a break in the retina, which is because of the focal degeneration of the neurosensory retina, and it is not associated with vitreoretinal traction. That means there is no role of vitreoretinal traction in the development of atrophic retinal holes. And since there is no role of vitreoretinal traction, you are not going to find any attached vitreous as a tag to that atrophic retinal hole. Now, this is something that you find classically in a horseshoe shaped tear, and this is because a horseshoe shaped tear will basically happen because of a vitreoretinal traction. Okay, now another thing that you need to remember with respect to all of these breaks is that how dangerous are they and how commonly do they lead to retinal detachment. Now, when we talk about atrophic retinal holes, they have not been linked to an increased risk of retinal detachment. That means what I mean to say is the risk of retinal detachment with a atrophic retinal hole is really, really low. Okay, now over here you can see some pictures. So an atrophic retinal hole may be a full thickness hole or it might be a partial thickness hole, and they are commonly seen within the area of lattice degeneration. Okay, so in our video on lattice degeneration we already talked about that, right? Now, what can happen is that sometimes fluid can basically enter these atrophic retinal hole and form a cuff of fluid around it, right? And eventually, very slowly, they can actually lead to chronic rheumatogenic retinal detachment. So this is a very slowly progressing retinal detachment occurring secondary to this atrophic retinal hole. But mind you that this incidence of RD following an atrophic hole is really, really low. Okay, now over here you can see that this is actually an OCT that has been taken at the level of the atrophic retinal hole. So you can see this is the cuff of fluid which is present here, and you can see this hole is actually a full thickness hole, and the ends of these hole is actually lifted because of the presence of this cuff of fluid underneath the hole. All right. Now, the atrophic retinal holes can lead to subclinical detachment. Now, subclinical detachment, as I already told you before in the previous videos as well, it is defined as those when the fluid extends more than one disc diameters on all the sides of the retinal break, but it doesn't really lead to bigger detachments, right? So that is known as subclinical detachment. So atrophic holes as such are not very dangerous because the incidence of RD with them is really low, almost about less than 2%, right? Now, RD secondary to atrophic hole typically can occur in younger patients with myopia, even in the absence of posterior vitreous detachment. Okay, now these patients, when they do develop these sort of RDs or retinal detachment post atrophic hole, their retinal detachment will be asymptomatic. That means they will not show any symptoms like flashes, floaters, or blurring of vision until fixation is involved. What I mean to say is until the retinal detachment reaches the macular area, right? So remember, atrophic holes might become dangerous in a myopic patient, especially a younger myopic patients. All right. Now, atrophic holes can also be partial. They might not be complete, and such atrophic holes might look like a partial excavation of the neurosensory retina. As you can see over here, this is a partial retinal hole, and you can see how it has actually excavated the neurosensory retina. Now, these partial retinal holes will usually not lead to any subretinal fluid development or retinal detachment, right? However, if there is a full thickness retinal hole, that can actually allow the transmission of fluid from the vitreous cavity into the subretinal space, leading to development of this rheumatogenic retinal detachment. However, these are very slow growing chronic retinal detachment, and the incidence is about 2%. Now, because the incidence is so less, there is no clear consensus for the treatment of such atrophic hole. Now, the treatment basically that we give is a laser prophylaxis, and here the whole idea of giving laser around that atrophic retinal hole, as you can see over here, is to develop the chorioretinal adhesions. Okay, and the idea here is that if you develop these adhesions in the retina and the choroid, that potential space between the RPE and the neurosensory retina is going to be lost, right? Now, as that space is obliterated, now the fluid can no longer enter through the hole into the subretinal area, and therefore the development of retinal detachment is prevented. Okay. Now, according to the American Academy of Ophthalmology latest guidelines, it says that if you have a patient with asymptomatic atrophic retinal hole, most often these patients are observed without any treatment or without any laser prophylaxis. However, there are some special circumstances where the patient is definitely considered for the laser or treatment. And these circumstances are, for example, if the patient has a high risk for development of the retinal detachment, that the patient is, say, already having a lattice degeneration, or if the patient is high myopic patient, or if the patient has had any previous surgeries like the IOL surgeries or cataract surgeries, if there's aphakia in the patient, if the patient is already having an IOL pseudophakia, or if the patient has a retinal detachment in the other eye. Now, these are some specific indications where you will consider treating these patients. Okay. The next tears that we are going to talk about are the horseshoe shaped tears or the flap tears. Okay, the name horseshoe shaped tears has basically been given because of the shape of the retinal tear that resembles a horseshoe. Okay, and here these are full thickness breaks in the neurosensory retina that results because of the vitreous traction and is usually caused because of the posterior vitreous detachment. Right. Now, these U-shaped tears are basically developed as the vitreous basically separates like this. So, the vitreous is actually going to pull a part of the retina also along with it, leading to development of a flap, and therefore these are also known as flap tears, right? Now, this part that is pulled here is actually known as the apex of the flap, and this is actually the base of the flap. Okay, so the base is attached to the retina and the apex of the flap is taken away along with the vitreous. Now, the development of these horseshoe shaped tears is most common in the superior temporal quadrant of the retina, followed by the superior nasal quadrant. So there will be a pre-existing vitreoretinal adhesion, and that strong pre-existing vitreoretinal adhesion in that area, as the vitreous starts separating, it takes away along with it some part of the retina, leading to development of a horseshoe shaped retinal tear. Right now, a horseshoe shaped retinal tear usually has this U-shaped appearance. Okay, these two anterior extension of these U-shaped tear are known as the horns. Okay, and this part is known as the apex of the tear. Okay, so the horns are directed basically anteriorly towards the vitreous space, whereas the apex is directed posteriorly towards the posterior pole. So as you can see over here, this is the posterior aspect, and this is the apex of the horseshoe shaped tear, and these are the horns, right? So what are the risk factors for development of a horseshoe shaped tear? Okay, you can again see a tear here. This is the apex, which is posterior, and these are the horns, which are anterior. And here you can actually see the presence of a lattice. Okay, the risk factors are pre-existing lattice degeneration, because those are the areas of dense vitreoretinal adhesions, and as the posterior vitreous detachment starts and it reaches this area of dense vitreoretinal adhesion, what is going to happen? It is going to pull along with it some part of the retina, leading to development of these flap tears. Then trauma can actually lead to the development of these flap tears, and they can also be multiple horseshoe shaped tears developing in traumatic cases. High myopia obviously is a risk factor again, right? Now, a very important fact over here is that usually patients will come to you with the complaint of presence of, new onset floaters and photopsia. Photopsia is nothing but it is a phenomenon of flashing light, and this occurs usually due to traction on the retina. So what happens is that in many patients, as the posterior vitreous detachment starts, patients are going to complain of photopsias. Now, the thing is that these patients who are actually having symptomatic posterior vitreous detachment or PVD, these patients should be observed closely. The reason is that the reason why because these patients should be observed closely is that such patients who have experienced symptoms with the posterior vitreous separation, they have about 15% risk of developing a retinal tear, and therefore symptomatic PVD patients should be closely followed up. Now, not all lights that the patients see are actually photopsias, okay? So you can see flashes of light in various other conditions as well. So in ocular migraine, you will have these zigzag multicolored lights. In occipital ischemia, there will be flickering stars that will be observed by the patients. And in acute zonal outer occult retinopathy, the patient is going to observe colored lights, okay? So it's very important that you differentiate photopsias from the flashes that can occur with other disorders as well. Now, sometimes what happens is that around that horseshoe shaped tear, you are going to see RPE hyperplasia. Not just around the horseshoe shaped tear, you can also find this around the atrophic holes, right? Now, whenever you see that black pigmentation around the retinal break, it basically indicates that there is reactive RPE hyperplasia, because the pigmented layer of the retina is what? It is RPE. Now, this happens in cases of long standing tears. Okay, so in long standing tears, the retinal pigment epithelium will undergo this reactive RPE hyperplasia, and as it undergoes this reactive RPE hyperplasia, it is believed that there is a denser adhesion in these cases between the neurosensory retina and the RPE, and therefore, whenever you see RPE hyperplasia around the break, what happens is that the chances of such a patient landing up into retinal detachment basically decreases. Okay, so that is one important point that we must remember. Okay, now another thing that you have to remember is the superior temporal breaks usually have a greater likelihood of development of a macula of retinal detachment. Okay, for example, as you can see in this picture, here is a break. The break is located in the superior temporal region, and whenever the break is located in the superior temporal region, there are greater chances of developing a bigger RD or a larger RD, and this RD going and actually lifting off the macula itself or affecting the macula. Now, such an RD is known as a macula of RD. That means the macula, the neurosensory retina of the macula also is affected. Now, it doesn't mean that only a superior temporal break will lead to a macula of RD. Sometimes even inferior breaks can actually cause development of a macula of RD. Over here, you can actually see sometimes there might be actually more than one retinal tear that is responsible for development of RD, and therefore thorough examination in these patients is very important. Whenever multiple breaks are present, they are usually present within 90 degrees from one another 75% of the time. Over here, you can see one break and this is another break. Now, what about treatment of these horseshoe shaped tears? Okay, so whenever you see a horseshoe shaped tear and the patient is complaining of acute symptoms of photopsias or floaters, then you have to treat them promptly. Okay, however, if the patient is asymptomatic and has a horseshoe shaped tear that is found on examination, then you can consider treatment based on the other risk factors that we discussed before, right? And we already know the goal of treatment here is to create that chorioretinal adhesions around the tear, and this will basically prevent the vitreous fluid from entering the subretinal space and creating a retinal detachment. Now, these are subsequent images post a laser prophylaxis around a retinal tear. So you can see over here, these are the fresh laser marks, and later on this pigmentation develops around the retinal tear, indicating that chorioretinal adhesions have basically taken place, right? So that was regarding the horseshoe shaped retinal tears and the treatment. Now, the question is, why not treat all of these cases? Why do you actually consider treatment, and why can't we just treat all these patients? The thing is that treating asymptomatic retinal horseshoe tears is actually less straightforward. Okay, about 5% of these patients will develop to retinal detachment. Now, it is theorized that even if you give extensive prophylactic therapy, even if you give extensive laser to these patients, just the laser itself can cause some of the changes in the vitreous, can stimulate some of the changes in the vitreous, and this can again lead to increased subsequent vitreoretinal traction, and that vitreoretinal traction can again lead to retinal tears, right? So if you treat also, there are chances that you might actually be creating iatrogenic retinal tears, and therefore you really need to weigh whether you need to treat the patient or just observe the patient, right? So special conditions again, where you need to definitely treat the patients is high myopia, family history of retinal detachment, the other eye is also having retinal detachment, syndromes like Stickler syndrome associated with retinal detachment, and if the patient has had a previous surgery like pseudophakia, and if the patient is a phakic patient, right? Now these patients usually have multiple breaks in the periphery. Now, coming to the third type of retinal break, and that is the operculated retinal hole, right? Now, operculated retinal hole, as the name suggests, they're usually going to have this overlying free floating plug of retinal tissue, which is known as operculum. Now, it need not be freely floating all the time. Sometimes it might just be attached at the edge of this atrophic hole, right? And these are basically attached to the posterior hyaloid of the vitreous. Now they're very similar to the to the horseshoe shaped tear, but over here you will have this focal areas of vitreoretinal abnormality. So they usually originate from the areas where there is focal vitreoretinal adhesion or abnormality, and the predecessor lesion for the development of operculated hole is usually a retinal tuft, right? Now, in the area of retinal tuft, usually there's an excessive strong vitreous adhesion, and the retina in that area is also weak. Now, whenever there's trauma or whenever there is a release of this vitreous traction post, say, for example, PVD, what happens is that the vitreous is going to pull this part of the retina along with it, leading to the development of these operculated retinal holes. So, operculated retinal holes are very similar to that of atrophic retinal holes. It's just that the atrophic retinal hole develops post degeneration, whereas the operculated retinal holes with the operculum usually develop post a focal vitreoretinal abnormality. Let us see some more examples here. So you can see this is this is a hole, and over here is the operculum. You can see over here this is the hole, and this part is the that lifted off area of the retina, which is now acting as a lid to that hole known as the operculum. Now the question is, are the operculated holes dangerous or are they not dangerous, right? Now patients usually with the operculate holes in the initial stages when that operculum is still attached to the retina, they are going to be symptomatic. Later on, as the operculum totally separates off from the retina, the patients will now become asymptomatic. Once the patient becomes asymptomatic, it means that the traction is now released, and the absence of vitreoretinal traction after the operculum now becomes freely floating. It translates into a very low risk of development of hematogenous retinal detachment. And therefore, when you have this operculated retinal hole, usually the treatment is not advised. So, according to these guidelines of AAO, you can see that if the patient is acutely symptomatic, you can still consider the treatment based on the risk factors. Coming to the important tears where you definitely need to actually treat these patients not just with laser, sometimes even surgically, and these are the giant retinal tears. Okay, so giant retinal tears are the tears which basically extend more than 90 degrees circumferentially around the retina, or we can say more than 3 clock hours. Okay, and usually they occur along the posterior edge of the vitreous base. So you can see this giant tear, the tear has actually folded, the flap has actually folded onto itself. So as I told you that in a giant retinal tear, you are going to see this tear. The tear is definitely more than 90 degrees and the tear is more than 3 clock hours extending circumferentially. Now this part is the anterior edge of the tear and this part is the posterior edge of the tear. And you can see that the vitreous in a case of giant retinal tear is basically attached to the anterior edge of the tear. Now this is a very important point. Now, giant retinal tears also develop in the areas of pre-existing dense vitreoretinal adhesions, and just like the horseshoe shaped tear, as the PVD starts, the vitreous is going to start separating, and as the vitreous starts separating from the posterior to the anterior region, it encounters this area of dense vitreoretinal adhesion, and since it's not able to actually separate clearly from the retina, it actually lifts the retina in that area, leading to development of this giant retinal tear, and then it moves anteriorly, and therefore what will happen is that you will see that the vitreous is still attached to the anterior edge of the tear, and in the posterior edge of the tear you do not find any vitreous because the vitreous has already been separated from the posterior edge of the tear. And we know that the vitreous detachment basically starts at the posterior level and then it goes to the anterior level. Okay, and that is the reason why we do not have any vitreous attachment to the posterior edge of the giant retinal tear. Now, this is a very important point. So, a giant retinal tear will have a strong vitreous adhesion at the anterior margin of the break, and the posterior margin of the break is free of the vitreous attachment. And a strip of retina is going to be seen attached under the vitreous plate at the anterior edge of the GRT. Now, because the posterior margin of the GRT does not have any vitreous attachment, due to gravity and because of the retinal elasticity, the posterior flap can actually flip on itself or invert on itself. As you can see over here, the anterior edge has the vitreous attached to it marked in green color, and you can see the tear has actually folded on itself. This is called the inversion of the posterior edge or flap because of the gravity and no support of the vitreous. Okay, over here you can see the flap has folded on itself. Coming to prognosis and treatment, as you can assume that these giant retinal tears, they will progress really fast to developing a total retinal detachment, and the prognosis is usually poor and the surgery is also quite challenging. Again, you can see some of the examples of giant retinal tear. You can see this tear is actually involving more than 3 clock hours, and here you can see the anteriorly there is still a strip of normal retina which is attached, and this is an area of giant retinal tear. This is the posterior flap. The posterior flap actually will not have any vitreous attached to it, and therefore it can fold on itself. Again, you can see a normal area of the retina here at the anterior edge, whereas the posterior edge of the tear has actually folded on itself, and what you see over here is the back surface of the retina. Coming to the last tears that we are going to discuss in this video are the giant retinal dialysis. Okay, now dialysis is very different from a giant retinal tear. Here, the tear of the retina basically results because of the disinsertion of the retina from the ora serrata. The PVD is not responsible for the development of this giant retinal dialysis. Okay, the vitreous is still attached to the posterior margin of the break because there is no posterior vitreous detachment. So as you can see over here, this break has developed because the retina has totally disinserted from ora serrata, right? And therefore over here what you can see is that the retina still has vitreous on top of it because there is no posterior vitreous detachment, right? And therefore in case of a giant retinal dialysis you will not see any inversion of the posterior margin of the tear, right? So in case of giant retinal tear, what did I tell you? That PVD is something which is responsible for it, and therefore the posterior margin of the tear doesn't have any vitreous support, and therefore the flap can actually invert on itself. Whereas something like this doesn't happen in case of a in case of a giant retinal dialysis because the posterior vitreous detachment is absent, and therefore vitreous is still present at the posterior margin. Again, you can see over here this is the anterior edge and this is the posterior edge, and the posterior edge has this vitreous nicely attached onto it. You can see over here some of the examples. This is the giant retinal tear, and the posterior edge has not folded on itself. And however, giant retinal tear again has poor prognosis. It can spread rapidly into the development of rhegmatogenous retinal detachment. So you can see over here the detachment has actually reached almost up to the fovea. So these dialysis basically are very common after a blunt trauma. Management is really difficult and the treatment needs to be tailored according to the individual patient. right? Now, in the end, let's discuss something about the traumatic breaks as well. So, traumatic breaks basically happen because of blunt trauma. This blunt trauma is going to actually compress the eyeball along the anterior posterior axis, and thereby, what happens is that there will also be compression of the vitreous and there will be expansion of the eyeball in the equatorial plane. Okay, now whenever this vitreous body, which is viscoelastic, it undergoes a slow compression, it doesn't have much deleterious effect on the retina. Whereas whenever there is a rapid compression of the eye because of blunt trauma, that can lead to severe traction of the vitreous base, leading to detachments over here, leading to avulsions of the vitreous base over that region, right? So traumatic breaks are usually multiple. They can cause ragged equatorial breaks. Trauma can lead to this ragged equatorial breaks. They are more common in the inferior temporal and superior nasal quadrant, and the most common of the breaks that you find during trauma are the retinal dialysis. You can find even avulsion of the vitreous base, and of course you can have horseshoe shaped tears as well, right? So that was regarding the retinal tears, retinal holes and breaks. I hope that was useful, and if it was, kindly hit that subscribe button. That makes a lot of difference to the channel. Thank you and have a nice day.